Welcome back to the Better Health Now podcast. Today, I sit down and talk with Dr. Erin Britt, the director of the hospice care here at Cullman Regional. Thank you so much for being here.
Thank you for having me.
Yeah, I'm excited. So before we dive into what hospice care is, let's talk a little bit about your background and kind of what your role here is and what sort of the day-to-day looks like. So what ultimately kind of led you to pursue a career in medicine?
Well, I knew since I was 6 years old that I wanted to be a doctor.
Okay.
I had a chance to help take care of my grandmother after several surgeries, and I just liked that aspect of caring for people and watching them get better and contributing to that. And so ever since then, it seems like everything in my life has kind of been geared towards becoming a doctor.
Yeah. We had someone on earlier, and she said it's either people that like healthcare either love it or they hate it. There's no in between when you're kind of going through those studies, especially with a career path that takes so many years to kind of achieve. And you have to be all in for it.
Right.
So as your role of director over the hospice care, what does your day-to-day sort of look like here at Cullman Regional?
So from day to day, it varies quite differently, and it really just depends on what my patients need that day. At least once a week, we have a meeting with all of the staff, the nursing staff. We talk about all the patients in our care and bring up any kind of concerns or care management that we need to adjust. Every day, like I walked in earlier right before we started this, and I was on a phone call talking about adjusting someone's pain medication to help better control their symptoms. And we're on call 24 hours. So
wow.
It can kind of, like I said, it just depends on what the patients need. What one of us is always on and ready as needed,
So what is really categorized as hospice care? What is hospice care?
So that's a really good question, because I think there's a misnomer or misunderstanding sometimes of what really is hospice. But it's really a medical service that is provided that, in my opinion, kind of addresses medical, spiritual and social needs for patients in a way that we're not able to in other parts of medical organization. So we have a whole team of providers. We have nurses, we have aides, we have a chaplain, we have social workers, and then, of course, you have your doctors. And all of us work together to come up with a care plan, and it's ultimately to take care of patients when they are in more end-of-life stages or have like a terminal diagnosis.
Okay.
And so I think there's I guess that answers another question, but like I said, there's a lot of misconception that hospice is just like you're dying right now, or
I would assume for each case is a little different,
right?
Depending on the level of need or the level of care they need, and depending on kind of what stage in their life they are too. Every case is a little different, and so probably your approach to maybe that new patient or that new patient for hospice care varies patient to patient.
Correct.
What does it look like for your team and the team here at Cullman Regional with the sort of the interactions with the hospice patients, and how frequent is that, and kind of what can the family maybe expect to see when a loved one is put on hospice care?
Yeah. So every patient, you're right, is very personalized and is going to be different to what their needs are. So we have visit-wise and like how often they're seen and taken care of. So as a standard schedule, nurses and like home aides come in 3 times a week at minimum.
Okay.
Doctors usually visit at least once every 2 months, but as I said earlier, we're every week sometimes on a daily basis being kept up to date virtually or, in the periphery. So even though we're not laying eyes on them, we're still managing their care pretty consistently.
Okay.
Chaplains come out pretty regularly. We'll have volunteers that come out just to spend time or help do things around the house that might be needed.
Yeah.
And then, like I said, a social worker. So they try to bridge the gap of what are some needs that either the family needs for support or financial assistance, or like how best can we just take care of every aspect of this patient. Then, if someone is having more trouble with symptoms, we can come out there in the middle of the night. The family calls us, they're struggling, they're hurting, we'll come out and we'll take care of them. If we do see that they're transitioning more towards the end of life at that point we see them on a daily basis and sometimes more than once a day.
Wow.
So it varies and it's personalized to what you need. But, that hospice is something that is, like I said, it's unlike anything else in the medical world, where we have the capability to just take care of you and know you on such a personal level we're just not able to otherwise.
Yeah. And I would assume too, though there's, like you said, there's so many different moving parts within hospice care with the different doctors and physicians and nurses and everyone else involved. I bet is there still sort of that communication with maybe some of their general practitioners that maybe they were seeing on a regular basis prior to hospice, that you're having then to navigate that conversation too, not just between you and the family, but you and their other physicians that maybe they were seeing prior to being put on hospice.
We do still keep in touch with their primary care doctors. It's not a necessity,
okay.
But especially if you've known someone for, taken care of someone for 20 years.
Yeah. It's helpful when you're at this part of their life to have that,
right.
Have that sort of backlog almost of
exactly.
hey, here's what the last 20 years has looked like.
Right.
And then here's what the next, 5 or 6 years could look like, or whatever that might be. Because I would assume the hospice care can vary depending on patient to patient,
right.
of how long that might last.
Exactly.
You mentioned a little bit earlier just about the misconceptions. What other sort of misconceptions do you think, or do you see that maybe people ask you on a daily basis, just people that maybe know you, that they're family friends, that maybe ask you that they think they know about hospice, but in reality, it's actually a completely different thing?
That's a great question. I feel like there are a few very, very common misconceptions. The first one I kind of alluded to earlier was that they feel like, well, you're just putting me on hospice and I'm going to die right now.
Yeah.
And that's not the case. Hospice just means that you have a terminal diagnosis, or a diagnosis that needs a lot of upkeep, that maybe you just don't want to have to go to the doctors that often, or maybe, you have cancer and the treatments are just more than you can handle and you don't want to pursue that any longer. So again, it does not mean that you're dying today,
yeah,
but that it just means that over time you will decline because of this diagnosis.
And then having those people in places with the hospice care that allows whatever time that may be to be as comfortable as possible.
Exactly. And probably another misconception is a lot of people get real worked up about is medications. And so they think that we're just here to basically over sedate you and, keep you out of it. And you're not even going to be able to communicate. And that's not the goal either. It's definitely symptom control, and symptoms are from pain, not sleeping, being nauseated, having swelling, having a cough. It's not just sedating medications, and so our goal is always just to make you have quality of life. So, we want you to be comfortable, but also want you to enjoy spending time with your family. So we try to find that balance and again, not just make you sleep the whole time.
Yeah. And you alluded to it a little bit earlier, but what are some of those maybe illnesses that kind of tend to allow the patient the eligibility to have hospice care?
Yeah, that is a long list, but some of the more common ones that we do admissions for would obviously be cancer, heart disease, heart failure, COPD and respiratory failure, chronic kidney disease, dementia, and end-stage dementia. Those are probably the more common ones that we have on our service.
So if someone's listening to this or watching this and they maybe think that their loved one is maybe ready for hospice care, how do you kind of help the families figure out the appropriate time to start hospice care? And is it an ongoing process up until that moment, or is it a relatively quick process once you think it's time?
So that one is, how we talked about, you've got primary care doctors, and some of us, we develop relationships where we feel like they're family, know them so well. And I feel like those are the providers that really are going to help get patients geared up for hospice, because they saw you 5 years ago, 1 year ago, 6 months ago, and they can see the difference. Yeah. And that's, in my mind, when I take care of patients in my primary care practice, that's typically when I start talking to families about considering hospice, when either I've seen such a significant decline in the last 6 months that I think, hey, this could be a good resource. Or, like I said earlier about cancer, maybe you're trying chemotherapy and there's radiation and you're just miserable and you're sick and you think this is not quality of life and I don't want to do this anymore. Or if you're going in the hospital over and over again and I'm sick of being in the hospital, I'm sick of going to the nursing home. Those are times when all providers, whether it's your primary care or someone taking care of you in the hospital, in our minds, that's when we try to start having the conversation with families about considering hospice. But really all it takes is a referral from your doctor or like a doctor in the hospital.
Okay.
And there's actually several agencies in our community and then likewise in other communities. And so you just pick who you would prefer to use, get a referral, and then that, case manager will come out and evaluate you. And
okay, and then from that, it then comes into your realm that then kind of then dictates, hey, here's the nurses that you're going to have, here's the level of care you need,
right,
here's the cadence at which you'll be out there and stuff like that. But if someone's listening and they want to take that first step, it is just sort of that referral or looking
right.
at providers in the area.
Right.
Okay.
And even if you're, a family member or you as the patient, you kind of feel like, I don't know if I qualify for hospice, and I feel like people underutilize hospice and they get on hospice too late. So it would honestly be more beneficial to let the nurses come out and evaluate you and see if you are qualified for hospice. The worst they can say is like, no, you don't really meet criteria right now, and then move on.
And I would assume too. I mean, we were talking earlier with someone on the podcast about just like there's those screenings and those routine visits to the doctor. I think that is probably a huge benefit for patients, for anyone listening, really, is to have those routine checkups so that they catch it earlier than maybe they typically would to go on hospice if need be.
Right.
Because you have that physician that seen you every year for the last 5 years and routinely can kind of see if things are happening and they're able to catch it a little bit earlier.
Right.
But I appreciate talking a little bit about hospice care and kind of the work you do here at Cullman Regional. We'll have links in the episode notes to everything that we've talked about. So if anyone wants to find out any information about you or the work being done here at Cullman Regional, they can visit the links there. But I appreciate you taking the time.
Thank you so much. I appreciate it.